I'm Andrea Trio, and I am the president of the Greater Kansas City HIMSS chapter. And I'm really excited about the lineup of presenters that we have today. We have Chad Austin from the Kansas Hospital Association, John Doolittle from the Missouri Hospital Association. So they're going to co-present on the state of healthcare in Kansas and Missouri. And then we have Molly Hess from Advent Health, and she is the director of advocacy and is going to talk about her role in the community and kind of her job and how we can be more involved as citizens. So really looking forward to it. There's a chat function at the end. They're all going to take your questions. If you want to type them in as you think of them, you're welcome to, but we probably won't address them until everyone is done presenting, and then we'll have time at the end of the presentation. From a Greater Kansas City HIMSS board, we are going to have a couple more events this spring. We're very actively watching COVID, as I'm sure everyone here is as well. We tentatively have our Boulevard fundraiser on the books for April, but we're going to just have to see what the environment and the community looks like. So keep that in mind. We're hoping we can get together in person again. But I know any of you who work at a hospital or have kids in school understand kind of the stress right now. So I'm going to go ahead and kick it over to Chad and John, and we'll start there. So welcome.
Thanks, Andrea, and I appreciate the opportunity to be here this morning to talk more specifically about some of the activities that we're focused on in not only the federal space, but also on the state space as well. And so as we look at today's agenda, a few of the things that we're going to talk about are the federal issues, but then also dive a little bit deeper into some of these state COVID-19 activities, not only in Kansas, but also in Missouri. And then we'll jump into some of our state-specific issues, as well as have a conversation about how everyone can get involved in some of our advocacy initiatives. And so really do appreciate the opportunity to be a part of this presentation today. John, any comments you'd like to say before we get kickstarted here on some of the federal activities?
First of all, thanks, Chad. You all will be able to tell as we go through this that he did the lion's share of the work on the slides, and he's just smarter in general. So I'm happy to be here today in a supporting role. I'll give you just a little bit of biography here. So again, John Doolittle, grew up in Northwest Missouri, lived and worked in Kansas City for quite a while. I was at the Federal Reserve Bank of Kansas City for about 9 months at the beginning of my career, and then followed my boss to Cerner Corporation and spent a little over 11 years at Cerner. For a little more than a decade after that, I was the president and CEO of my hometown hospital up in Albany, Missouri, which is about 100 miles north of Kansas City, and got to serve on the board of trustees for the Missouri Hospital Association during that time. My predecessor, Herb Kuhn, has worked with Chad and Chad's predecessor to do a similar presentation to this in the past. Herb did a fantastic job for the Missouri Hospital Association and decided to retire. And when he did, we went through a search process, and I was selected as the new CEO here in Jefferson City. Started that on October 18th. And that means I'm still, relatively inexperienced and a little bit nervous about visiting with you today, but we'll try and make it worth your while and look forward not only to sharing some information with you, but definitely questions and conversation. I think it'd be a lot of fun. So thank you for all that.
Thanks, John, and congratulations again with your new position. We look forward to working with you in the bi-state area as well. So what we wanted to do was just to highlight and talk about some of the federal items that I know our associations are focused on. And one of the items that we wanted to highlight that's a priority issue for us that we're keeping a close eye on deals with the Medicare sequestration holiday. And you may recall that sequestration started right around, I believe it was August of 2011. And during that time, to give you a little bit of history, Congress created a so-called super committee to design an alternative package to achieve some budget savings in the amount of about $1.2 trillion. Unfortunately, back in 2010, 2011, that super committee wasn't so super as they were not able to come up with any type of an agreement. And so in essence, what occurred was a 2% reduction in Medicare payments and a 2% reduction for defense spending. Well, a few years ago, Congress did remove the sequestration on defense spending, but allowed the Medicare sequestration to continue. And towards that end, Congress did pause the 2% sequestration for Medicare during the COVID-19 pandemic. And so since that point in time, we have been working with our congressional delegation members to really delay any type of reenactment of the Medicare sequestration that would go back into place. Congress back in December actually put on a moratorium that extended the holiday period so that sequestration is not in place until April 1st, where at that point in time, 1% reduction would go into place on Medicare payments. And then that would increase back to what the original sequestration is, would be 2% as of July 1st, 2022. Well, it will be something that we'll continue to work on from a hospital association perspective. The impact that it has on our state is significant, especially when you look at not only the percent of payers under the Medicare program for many of our hospitals, when in fact you look at some of our rural hospitals, Medicare may make up 60, 70, 80% of the payer mix. And so it is something that we'll continue to work on from a federal side. Let me see if I can get the next slide going here. 1 second. Oh, I'm going too fast. There we go.
So I'll jump in here and talk a little bit about COVID-19 policy issues. And so again, we deal with COVID-19 policy issues at every level of government, right? From school boards, cities, counties, states, and federal. This slide's really kind of the federal section, and talk to you a little bit about what's going on. There have been several different tranches of relief funding, different congressional actions over time. And, you know, what folks realize is that COVID has caused extraordinary spending by healthcare providers, including hospitals and health systems throughout. And I think overall there has been a proper sentiment toward making sure that folks have the cash and cash flow that they need to keep up with demand. So we've seen supercharged markets, whether it's for supplies when they were short, or especially on the workforce side. I think everybody's aware that you know, workforce shortages and increased demands on the system have led to a really supercharged labor market in some areas. And so, you know, what's the strategy and how do we get out of that are things that a lot of health systems are really worried about. And right now they sort of have no choice but to go along for the ride and make sure that they are competing and trying to have the folks in place that they need to provide care. This provider relief funding, you know, there have been different rules over time. Things have evolved. Like I told you, I was a hospital president, you know, 4 months ago, and was thinking about this from a very different perspective, which is, you know, thank you for the money. What are the rules? How often are you going to change them? Are you going to actually change them after the deadline? And, you know, what do we get to keep? What do we have to give back? And it has been confusing. We continue to advocate and work for additional tranches of provider relief funding. You can see that a phase 4 distribution began in December, and that helped provide more certainty from a cash flow perspective. The work that tends to happen on this side is to continue as the stances continue to dictate additional spending and preparedness activities, continue to ask for appropriate support from governmental sources to help fund that. You see that kind of last little dot point there. Will there be additional funding distributed to help offset costs and losses of the current surge? Clearly, we're advocating for that. We're also advocating for flexibility on when and how providers justify being able to keep what they earn from previous phases. You know, there's a lot more that goes into COVID-19 policy issues, trying to make some things permanent around flexibility to use telehealth and funding for telehealth, and trying to help us, you know, kind of never let a good crisis go to waste, they say, when it comes to seeing changes that we've made to the way teams have worked together and services have been made available, and hope that we can codify some of that on a long-term basis. Check my notes here. You know, investments in new models of care, hospital at home, perhaps some other things like that are promising. And then also further investments in the hospital preparedness program and other kind of disaster prep things. How are we going to be ready for the next thing that comes up, whether it's additional waves of COVID or it's something else? You know, we tend to value efficiency so much, and we don't necessarily build excess capacity, whether you're talking about last year trying to get electricity in Texas or whatever it is. When we try and make changes in supply chain, and I forgot to turn off my ringer, excuse me. When we try to efficiency at all costs, we tend to take a lot of capacity out of the system. And so continuing to advocate for appropriate preparedness funding and activity is something else I think is really important for COVID and otherwise. Vaccine mandate, we want to touch on this quickly. It's a little bit old news now. We see what has happened. The Supreme Court took a very unusual step here of hearing arguments on both the CMS and the OSHA vaccine requirements. Did that on January 7th. A little less than a week later, came out with rulings and left the CMS mandates in place for healthcare providers, continued the stay on the OSHA vaccine requirements. Those are ones that would impact employers 100 or greater. So here we go. An awful lot of hospitals and health systems and other organizations that are subject to CMS had already put vaccine mandates in place ahead of the deadlines, but many had not. What we've seen so far is that for those who have, there has been a little bit of a concern and an effect of people who are either vaccine hesitant or just mandate hesitant. And those are two different things, I think. Leaving those organizations, potentially to go work elsewhere or retire, whatever it is. And I think a lot of systems have reported a 1% to 2% change in workforce related to their own mandates. In the states like Missouri that had challenged the CMS mandate and actually went to, so there were I think 24 states that weren't yet subject to CMS while others were, as the lawsuits played out. Now the entire country is subject, although there's still guidance that says we're not going to check this. We're not going to check anybody in Texas yet. They've kind of got their own thing going. But for the other 49, there's guidance out about making sure that folks who want to participate in Medicare, Medicaid, CMS governed programs have compliant programs in place by February 14th. And so that's where we're headed. And the hope is that we'll continue to see a relatively minimal impact on the capability of the workforce, and we'll see enhanced safety as a result of vaccine mandates being in place. That will play out in Kansas and Missouri, two places that had not been subject to CMS while we were waiting for things to go through the courts. And we're trying to make sure that we're providing good information to members about what exactly the requirements are and what they need to have in place, essentially 30 days from when the ruling came down, February 14th. So there's plenty we could talk about there, but I hope that was a useful survey of some issues related to COVID.
Yeah, thanks, John. And I know in Kansas, the whole vaccine mandate has been something that's been top of mind for our hospitals ever since this started being discussed last summer with the announcement that there would be some type of vaccine mandate in place. And I think now that we have a little bit more certainty, we can work with our hospitals and provide them the needed tools and information so that they can prepare themselves, whether it's putting all the requirements in place as is, whether it's looking at any type of exceptions for religious and medical exemptions that are out there. There's still some additional work I know that we're working on from an association perspective for hospitals across the region as well.
And Chad and I both talk about this later, but kind of while we're on the topic, there are folks who have opined about what the difficulty would be if a state tried to say that folks who do business in that state can't have a mandate, and yet in order to get paid by Medicare, Medicaid, and others, or basically keep your doors open, that you have to abide by the mandate. And so we're not seeing that yet, but you never know what's going to happen from a legislative standpoint in any particular state. And I think there's almost certainly more news to come when it comes to those issues.
Yeah, I think you're right on that, John. And I'll talk about this later on in the state policy issues for Kansas, but we did have a special session last fall where we talked about vaccine mandates, and there was legislation that was passed in Kansas. And now, from our perspective, we have to figure out how that legislation squares up with the mandate that's now being put in place by CMS. So stay tuned for some more information on that. Also want to kind of highlight another topic that's top of mind, I know, for many of our hospitals in Kansas, and it's the 340B program, which is really an essential program for many of our Kansas hospitals. The program, if you're not familiar with it, requires pharmaceutical companies participating in Medicaid to sell outpatient drugs at discounted prices to healthcare organizations that care for many uninsured and low-income patients. In Kansas, we have about 80 hospitals that are participating in the 340B program, many of which are critical access hospitals, but we have several urban hospitals that are participating in the program as well. From our perspective, the program, quite candidly, has been under attack over the last several years by the pharmaceutical industry trying to whittle the program down. And so we've been putting efforts in place, not only on the federal side, working with our partners like the Missouri Hospital Association and the American Hospital Association, but also having conversations in our state legislature looking at what can we do to protect the program and keep the program and the benefits that are provided to our patients whole. And so that's a topic of discussion, I know, from our vantage point that we're really looking into. John, from Missouri, I'm anticipating that you're paying close attention to this as well.
Very much so. Had a conversation yesterday with the chief financial officer of a medium-sized, health system, just a few hospitals, but one's a sole community and one's a critical access hospital. And basically with drug companies stopping behavior that they'd had before around providing discounted drugs to contract pharmacies on behalf of those qualifying hospitals. Just where we are right now as we wait for this lawsuit to resolve, for that medium-sized organization, it's about a $12 million a year hit to their bottom line. Many rural hospitals, critical access hospitals that are 340B, absolutely have counted on 340B. What a lot of folks don't know is over half of the critical access hospitals, maybe we do that definition real quick. Those are hospitals 25 beds or less, 25 inpatient beds or less, a special designation for conditions, participation, and payment under Medicare. And they're prevalent both in Missouri and Kansas. I think we have 38 in Missouri, and I think it's a larger number in Kansas, critical access hospitals. Over half of them, even headed into the pandemic, were running operating losses each year. And maybe they were break even or doing a little bit better on overall cash. For many, 340B was thought of as the difference between keeping their doors open and not. And so this assault on what 340B was by the drug companies, is really thought of as maybe an existential crisis for many of those hospitals and health systems. And we're watching as it plays out at the federal level, doing everything we can to support. And it's incredibly interesting right now. There's a bunch of lawsuits. The verdicts don't all agree with each other. There have actually been members of Congress write supporting briefs against the federal government in regard to the way things have gone so far. This will continue to play out, but it gets an awful lot of attention from us, our members.
Thanks. Whoops. The next topic that we just wanted to highlight that is something that just started going into effect on January 1st, 2022 is the Surprise Billing or No Surprises Act. The surprise billing has been an issue, I know, for many hospitals over the last several years. And quite candidly, it pits providers against insurance companies, but also having the patient stuck in the middle. And I think that's been one of the items that our congressional leaders have been trying to address, is to remove the patient from those negotiations and discussions that are going on. And so Congress is attempting to remove the patient from that situation and provide an opportunity for providers and insurance companies to work out some of the differences. The No Surprises Act, as I mentioned, does become effective on January 1st, 2022. From our perspective, we're still going through and kind of following some of the guidance as it's rolling out. I know it has created some questions from a provider perspective, but it is something that I think is top of mind for many of our hospitals as we move forward talking about that topic. Any reflection, John, from your vantage point on this topic?
I think this is one of those, the devil's always in the details, right? I don't think most members disagree with the philosophy behind this. Nobody wants to see patients get caught in the middle. It really depends on who's writing the rules and how that's getting done. There is, somewhat unsurprisingly, tension between healthcare providers and some managed care organizations on this, as well as the regulatory folks in Washington around some of the transparency pieces. And so this is a politically popular concept with good reason. And what's happening now is kind of working out the details.
Yeah, it'll be something we'll need to continue to closely monitor with many of our providers and hospitals. Wanted to kind of at least take a few minutes and talk a little bit about the Build Back Better Act, which is one of President Biden's centerpiece of his domestic agenda. There are a number of major provisions that have been talked about as part of this legislation. It ranged from looking at universal preschool for children to free community colleges, expanding Medicare services. So you may have heard about expanding services for hearing and dental needs, as well as the Medicaid program throughout the country. There were aspects and provisions related to this legislation that would allow the government to negotiate on prescription drugs with pharmaceutical companies, which is something that's been talked about for many years, but has not yet been put into statute on the federal side. And then there were also some more social aspects of providing some tax cuts for families with children and child care support, as well as paid family leave as part of the Build Back Act. Some of the parts that weren't included that I know created a little bit of consternation on the federal side when the House Democrats were looking at this is that there wasn't any provisions related to climate reforms. There wasn't the provision related to Medicare for all, which was something that was quite candidly talked about throughout most of 2021 as a potential centerpiece related to this legislation. And then also looking at areas as student loan debt forgiveness, I know was another item that was talked about as well. What happened with the legislation is that it did squeak through the House after the provisions were put in place, where in essence it passed on a 220 to 213 votes. All Republicans in the U.S. House voted against it. There was actually one Democrat who voted against it as well. In the Senate, it went over there, and all 50 Republicans, anticipated or expressed that they would be voting against it. And then from a Democrat's perspective, the only way that they were going to be able to get to move forward through the reconciliation instructions is that if all the Democrats voted for it, and it was a tie 50-50 with the vice president coming in and breaking that tie. However, you probably have seen there's been a lot of discussions with Senator Manchin from West Virginia that indicated that he opposed the current version. And so the legislation that was being considered at the end of 2021 has not moved forward, but it is something that potentially could be talked about as we move forward in 2022. One provision that I just wanted to kind of highlight from a Kansas perspective is the portion that contained cuts to the DISH program and uncompensated care pools to non-expansion states. And so this is something that from a Kansas perspective, unfortunately, we're still one of 12 states that has not yet passed Medicaid expansion. And so there was some criteria that was included in the Build Back Better Act that in essence would provide some additional coverage for individuals that were uninsured and would be eligible normally under Medicaid expansion for Kansas. However, in order to offset some of that, there would be reductions related to our DISH program and the uncompensated care pools. Well, the caveat with that is that from our perspective, it didn't square up and line up appropriately because this federal policy may allow more people to have coverage doesn't necessarily mean people are going to sign up for that. And so it did create some consternation, I know, within our membership as well as with our congressional delegation. We did work with folks on the federal level to be able to express our opinion on that. There was some discussions over on the U.S. Senate committee that in essence removed the DISH cuts, but it did retain the uncompensated care cuts. But it is something that if something does move forward, we'll continue to work on that and focus on that from a Kansas perspective. John, any comments on either the Build Back Better Act or any other federal items before we jump into talking more specifically about COVID?
I think your news outlets are probably better at this than I am. I think everybody sees what's going on. I think there's one thing you and I haven't said yet, Chad, that's relevant, especially back at the beginning. We were talking about sequestration, some other things. Feds are going to run out of money again on February 18th unless they pass something. And so it's really this crazy cycle going on in regard to appropriations, debt limits, ceilings, and all these other things. The can gets kicked down the road a little bit at a time. And that's why the American Hospital Association and others are continually sort of tuned in to what the mechanics are going to be on that. And February 18th is another big milestone that's coming up. It is our hope that, just as Chad highlighted, where we were able to put off and delay some of those sequestration pieces coming back into place, that we'll be able to make the case that COVID is unfortunately at least as alive and well as ever across the United States. And it's not time for those things to go away yet. And we'll continue to take kind of this incremental approach to pushing things out and trying to get additional funding. At some point that runs out, and we try to make sure that the membership understands that you can't count on some of these things going away forever, but that we are advocating, at the margins, I guess, and in a kind of a time box way to help as much as we can.
Good points, John. Thanks for sharing those comments. Now we want to transition and talk more specifically about some of the COVID activities that are happening within each of our individual states. And so wanted to kind of share this graph that's on the screen right now, but also talk a little bit more specifically about the background on COVID-19. Obviously, over the last 2 years, it's been very exhausting, not only for our society, but even probably more so for our healthcare industry and our healthcare professionals that are working in many of our settings, including our hospitals. And when we look back, or when I look back over the last couple of years and seeing the several waves that we've had with COVID, each of those waves we've faced challenges. And you may recall at the beginning of the pandemic back in March of 2020, some of the challenges that we were experiencing at that point in time focused on testing strategy, getting enough test kits out there. We've also faced challenges at the very beginning related to personal protective equipment, making sure we had an adequate supply for our healthcare professionals as we were bearing down on what we were seeing as the initial round and surge of COVID-19. And as John mentioned, from the PRF funds, we had challenges related to financial stability and lost revenue that some of our hospitals were experiencing. Since that point in time, with the initial wave, we've had other waves that have come through, and some of those needs that we've been focusing on have been on staffing needs. Last year, around this time, we were ecstatic about the opportunity to have a vaccine that we could make available not only to our healthcare professionals, but also to the general public. We worked through mechanisms to get distribution throughout all 105 counties in Kansas. But those were items that we were dealing with last year. And now in this current surge, really a lot of the conversations that we've been having with our members have really been focusing on staffing shortages and shortages of therapeutics and other drugs. And as we look at staffing shortages, some of the reasons why we're seeing some of the shortages that we have currently is that even before the pandemic, we had shortages in many of our healthcare positions like nursing, et cetera. But we've also seen over the last couple of years early retirements. We've seen people pause their career, maybe take care of their children or sick family members. We've seen people move to other settings. So maybe leaving the hospital setting and working in a primary care setting, working for a staffing agency, or maybe even looking at just a new career outside of healthcare. And then we've seen challenges in the recent surge as it relates to the spread of the variant Omicron and some of the isolation and quarantine requirements that are out there that are creating some challenges for our hospitals of losing staff who are now effective or in quarantine due to COVID-19 as well. When you look at the graph on the screen here, just want to kind of highlight that the graph illustrates the number of hospital patients with confirmed COVID-19. And as of January 16th, there were 2,036 cases, which if you look at the line graph is higher than any of our peaks in 2021. And so it is something of concern as we've been talking with our policymakers, with the general public, of really just putting in perspective where we're at as it relates to COVID-19 trends within our state. On the next slide, just wanted to kind of highlight a few of the items as we look at it by region. And Kansas continues to see an overall increase in COVID-19 cases throughout the state. And I believe the last we looked at it was about 13%. And we do break it down by KHA regions. And the largest incline that we're seeing here in the last week has been in Northwest Kansas with a 70% increase and in Southeast Kansas with a 57% increase. We're hoping that we're starting to peak, but at least at this point in time, it does not appear as though, unfortunately, that we're moving in that direction. We have been working on some modeling and following some modeling that's been out there as well that anticipates that between now and the end of the month that hopefully we'll start seeing a peak in terms of the number of cases that we're having within our state. The other area that we're focused on as it pertains to COVID-19 and monitoring very closely within Kansas is vaccine distribution and acceptance within our state. And from a vaccine perspective, Kansas has reported, I believe most recently, about 4 million doses that have been provided. And out of those 4 million doses, I think the last I recall, it was about 1.9 million for the first dose that has been provided. 1.5 million of a second dose that's been provided, and about 640,000 of a third dose. When you look at the population within Kansas, about 61% of Kansans have received at least one dose. And I believe we have about a little bit more than 52% of Kansans have received the completed vaccination series. As we look at the regions, and this graph here depicts that, or these 6 regions. The region with the highest vaccination rate is in Northeast Kansas and North Central Kansas, where we see about 63% of the population that's been vaccinated. And with the 2 regions that we have that have the lowest vaccination percentages are down in Northwest Kansas as well as Southeast Kansas, with about 48% of their population is vaccinated. The next graph, basically the heat map, identifies some of the COVID-19 vaccination rate as a percentage of county population. And you can see in Northeast Kansas, specifically with Johnson County, it has the highest percent, where it's 73%. And Wyandotte County, obviously in the metro area, has a 59% population that has been vaccinated. But you can also see, looking at that map, that we have several counties that are still hovering in the 30% range. And so that's one of the items that we're focused on as we're looking at COVID-19, as to how do we provide more information, more education, and promote vaccinations as a way to really get through this latest surge. And so some of the items that we're focused on from a KHA perspective as it relates to COVID-19 is that we are working with our hospitals on promoting mitigation steps, such as wearing masks, social distancing, washing hands, and getting vaccinated. And we're not only doing this as a healthcare industry, but we're actually reaching out to some non-healthcare related groups to really broaden the message out to the general public. And so we've done PSA announcements with other types of partners like the State Business Chamber, the Kansas Farm Bureau, and the ag community, reaching out to that population as well as working very closely with our physician partners from the Kansas Medical Society. In addition, we're working on ways to explore addressing some of the staffing needs that are out there, and not only looking at this from a short-term perspective, but also a long-term perspective. And some of the short-term approaches that we're focusing on is looking at opportunities to provide some additional funding to hospitals. We did that working with our state elected officials back in October, November timeframe with the Spark funding that was made available. In essence, there was $50 million that the state of Kansas allocated to hospitals to be able to use for retention efforts. And so those funds have made their way through to our hospitals, and our hospitals have passed that along to many of their frontline workers across the state. In addition, we're working on eliminating some of the regulatory barriers through the recent emergency declaration that the governor announced last week and the subsequent emergency orders that she's been putting in place. Those emergency orders are set to expire actually tomorrow. And so we're working closely with our elected leaders to try to put some of those emergency order provisions in statute for at least the foreseeable future, whether it's through May or whether it's through the end of this year. There's conversations that are happening in our state legislature related to that. And then trying to really focus on some long-term initiatives as we're looking at staffing and really trying to encourage and draw attention to our younger population about the great opportunities that are available within healthcare. And I know it's been a trying time. It's been an exhausting time for many of our healthcare providers over the last couple of years, but this is such a great industry still. There's a lot of inspiration that happens. The care that's being provided not only in our hospitals, but within our other settings is by far the top notch. And so trying to get that message out to our younger populations to really focus on what we can do as a state to be able to support our healthcare providers. So that, in a nutshell, gives a little bit of background on some of the activities that we're focused on from a COVID-19. John, I want to turn it over to you and relinquish control of the slides so that you can walk through what's happening in Missouri with COVID-19.
All right. And I have requested control, and we'll see how that goes. We'll stay here for just a minute, though, because once we start into the pictures, my eyes will be drawn to them. Chad did a great job talking about a number of areas. And of course, we're doing very similar things in regard to messaging, workforce, working with many to try and come up with good strategies around testing, including trying to move testing sites away from hospitals and emergency departments. Anything we can do to decompress emergency departments in particular and hospitals and still provide better than adequate, great care, as part of the overall health system that we think is very valuable right now. And then one other thing that I know Chad also is working on, it's on my list, and it's something I'll highlight because it's in addition, is just where we are right now on treatment. And so particularly outpatient treatment. One of the big strategies in previous waves, and we think it was successful, we're becoming much more organized and aggressive on outpatient therapies soon after diagnosis to help folks not need to be hospitalized, even if COVID positive. And so monoclonal antibodies, huge part of that. And as we moved here from Delta to Omicron, we unfortunately discovered that many of the products and drugs we had been using that had been effective against previous strains of COVID were not seemingly effective against Omicron. And so you get down to basically one monoclonal antibody, Sotromabab, Vimab. I always do that, and I need to unlearn and relearn because I transpose the V and the M there. But there is tremendous demand for that particular product right now, not just in Missouri and Kansas, but across the country, because the speed of the Omicron wave really has been different from previous waves of COVID. Whereas before, as a nation, we were able to understand hotspots, and we saw significant variation, even within states and regions. This thing has moved so quickly that a number of the sorts of resources that we had used previously and sort of moved around the country and were able to deploy to hotspots, the speed of the Omicron wave has confounded that approach. And so we, in Missouri last week, when ordering those monoclonal antibodies that are effective against Omicron, we got about 8% of what we had ordered. So there's a process at the state, bring it in, take orders, monitor inventory, and then allocate that scarce resource across healthcare providers in the state. And if you can only fill the warehouse with 8% of what you need, it makes it awfully tough to get everybody what they need. And this has been going on for weeks. So people who had supply have exhausted it, and it's really exacerbated the problems. There are other treatments that are being used and are available. There are some oral antivirals. Our sense is that some work better than others in this case, and those also are in short supply. There's products that can be used prophylactically ahead of infection. Those are in better supply. And then, something that's become much more common now are outpatient infusions of remdesivir, a fairly expensive and fairly labor-intensive front end treatment, but if it helps to keep people out of the hospital, certainly we think is worthwhile. And so that's kind of what's happening a little bit today on the treatment side, is even some of the plays that we were running earlier in the pandemic in different phases or waves, unfortunately have become far less available to us now. So with that as background, and then otherwise agree with everything Chad said, we're working on flexibility, working on waivers. The state of public health emergency had been declared in Missouri. It had been reduced significantly in August of 2021, and then it was allowed to expire on December 31st. We, along with many partners, had advocated for the extension of that public health emergency. We were unsuccessful. The good news is we have a lot of great relationships with state government here, and Department of Health and Senior Services and others have worked with us to basically do everything we can from a regulatory standpoint to preserve flexibility. And then we're pursuing additional things that seem to be precluded by current law, either with a legislative strategy or with some creativity from a regulatory standpoint. We'll continue to work on that, just trying to help our members take care of folks. The pictures I'm going to show you now, if I can figure out how to click forward, I definitely hit the arrow here. Let's see what happens. I believe I have control, but I'm having trouble driving forward for some reason. Let's try a different arrow. Could you just go to the next slide for me? Somebody else that can drive, because we didn't get there.
Yep.
So more of the same here in regard to suspected and confirmed COVID-19 hospitalizations in Missouri by region. You can see that Kansas City in orange there, was starting to be hit hard by Omicron, a little bit ahead of St. Louis. The good news for those in the Kansas City area, despite the fact that it's been incredibly pronounced and difficult in Kansas City, is that the slope hasn't actually risen quite as quickly in the Kansas City market as it has in St. Louis. But still, these are easily record numbers of COVID hospitalizations, right? You can see that previous waves, we never got above 300 or 3,000 COVID hospitalizations in the state of Missouri. And as of Tuesday of this week, we set another new record, 3,784 hospitalizations. It feels like we are headed north of 4,000 relatively soon, which is incredibly unfortunate. Let's go next slide, please. We similarly to our friends at KHA are able to track this and do modeling on a regional basis within the state of Missouri. And what you can see here is we have seen decreases in some of the rural areas in the northern part of the state recently. However, case data there is going back up instead of continuing down. And so unfortunately, that looks like the hospitalizations tend to follow a couple weeks behind new case data. And it looks like the decreases we saw there in the north may be short-lived. In the meantime, again, you're seeing incredible change in hospitalizations in the other segments of the state. And, Chad was talking about Southeast Kansas. Okay, well, that's just across the border from Southwest Missouri. And unfortunately, what we're seeing is a major increase, even since this data was compiled in Southwest Missouri, the Springfield area. And that is an area that's been hit. And you can see you got 5 hospitals down there that are below 10% remaining capacity overall. And the picture is also not good when you look at ICU specific capacity. Then there's also, since we're talking to a HIMSS group here, fascinating questions about how this data gets reported, how well we're able to do real-time capacity monitoring, and then how it flexes up and down based on the availability of staff, right? So you may have a certain number of staff beds on a normal day, but when 10% of your workforce is out, what's the effective change in capacity? And those are all difficult questions. We have models built. We do the best we can to understand what's really going on out there. Kansas City Star, I think, has done an excellent job this week of giving folks a little look behind the curtain at what's actually happening in hospitals and talking to clinical folks who are providing that level of care. And I hope they and other media outlets really continue that look. I think it makes it more real. And I think it really does help people understand the heroic work that's going on. But yeah, the numbers here are daunting. Again, I showed you here something that added up to 3,629. That was Monday. And then by Tuesday, we had boosted that number by another 150. And it looks like most of the arrows are still going in the wrong direction. It's not my nature to be an optimist, and certainly COVID has not taught us, it's taught us humility and it's taught us curiosity. It surely hasn't taught us much optimism. Right now, the models in Missouri are being refined. We try and understand what the impact will be of the current vaccination rates, of immunity acquired from being COVID positive, perhaps in recent waves, and how much Delta immunity carries over to Omicron, a whole lot of other questions that we're asking and trying to answer now. The best data I think I've seen and the best modeling we have available right now has us continuing to go north, probably significantly north of 4,000 hospitalizations around the state of Missouri, because the new ones are coming in faster than we are getting people discharged from hospitals. And the overall question about Omicron, is, okay, well, it rose very quickly. Does it seem to be declining quickly as well? And case numbers probably decline a little faster than hospitalizations, because those hospital stays are many days in many cases. Right now, I guess I would say I am hopeful that we'll see a peak across the state of Missouri, and particularly in some of our more populated areas, in early February, 2 to 3 weeks out. Let's hope that turns out to be true. That's kind of some of the modeling that we're seeing, but it's probably not going to be nearly as quick to return to normal levels in regard to hospitalizations as it might be in new case growth, because of the duration of those hospital stays and the intensity of those stays. Next slide, please. Again, just another look at capacity. Inpatient bed capacity is better than ICU bed capacity, and we also have to be humble about knowing what that actual capacity number is on any given day related to the availability of staff. Couple more. So you just see right now we're tracking individual hospitals, major hospitals, and then smaller hospitals around the state that are telling us they're at or near capacity. We've been hearing from members, that emergency departments in particular are running 100, 150, 200% of capacity for some time. And there's real difficulty as the system gets backed up in moving patients along normal lines of transfer from emergency departments to the floor or to the ICU within a hospital, and from smaller hospitals to tertiary quaternary care centers. One more slide, please. So there's your smaller hospitals that are reporting similar capacity constraints. Anyway, that's a not so cheery look from Chad and me at the current state of affairs regarding COVID in Kansas and Missouri. And I just, in addition to a lot of, I guess, smaller things that we are able to do, I should highlight a couple of those. We really are just trying to get messages out to the public about what they can do to help modify their behaviors in ways that are less likely to result in an overwhelmed hospital system in this state and elsewhere. A couple of kind of cool things that we've done just in the last week. One, we heard about something that was happening in Kansas and tried to make sure we were leveraging it in Missouri as well. It's a thing called NETCN, NETCCN, and it's from the federal emergency preparedness folks, but there's a recognition that COVID has prompted nurses, docs, and others to care for a type of patient in some cases that normally wouldn't be theirs to care for, right? There just aren't enough ICU beds. And so this is a bit of a just-in-time resource, and it can be used in a couple different ways. You can onboard this service and use it as a kind of real-time advisor for nurses and docs who are providing patient care in a hospital. Or it's actually well enough organized that they've got Missouri licensed physicians who can join the medical staff on a near-term basis and use this platform. It's a tele-platform to actually even provide care within hospitals if they choose to onboard as a NETCN kind of affiliate. We heard this was happening in Kansas. We investigated on the Missouri side. We had 21 hospitals onboarding right now. I think 6 are live, 2 more are live coming today. And early on, they are reporting that it is very useful to have that additional expertise and kind of real-time support. So that's been one thing that we think has real promise. And we appreciate the folks in Kansas and elsewhere that we're doing this and helped us ask and answer some questions on the Missouri side. The other interesting thing that's gone on from a staffing standpoint is there is a sort of staffing agency of paramedics and EMS personnel based in Montana. And they have tremendous seasonality on the needs for those services based on wildfires and other things that are happening out there. And this happens to be a season where they have some trained folks who might be able to come and help out. I talked about the fact that so much of this is happening nationwide at the same time, and the ability to move nurses from Vermont to Missouri is just not there. But this is an additional thing that we've tried to talk about from a regulatory standpoint. What can EMS personnel do inside an emergency department or outside of the hospital to help decompress and try and play matchmaker potentially on a new staffing strategy? The point here is we're all looking everywhere for help, and it requires real creativity. We understand the heroic work that our members are doing very well. We're on the ground with them. We're in the details of moving around monoclonal antibodies and other treatment resources. We're working on workforce, and we're trying to help provide that level of encouragement and flexibility and support in what is already a very difficult time and projected to get a little worse in the next few weeks. I guess I should have waited. I should have gone to my next slide for some of that, but I think we've covered it. So Chad, I think I can kick it back to you for the Kansas overview.
Great. Thanks, John. And Andrea, if you want to move to the next slide after this one as well. And just want to kind of give a little bit of update on what we're doing from a Kansas legislative perspective. And so quite candidly, there's been conversations leading up to the 2022 legislative session on what are the priority issues that we do anticipate will be coming up during this legislative session. And I know you'll learn a little bit more about legislative activities in both Missouri and Kansas with Molly. She'll have a lot of great information to be able to share. But what John and I wanted to do was to talk more specifically about our respective associations and what are those activities that we're going to be focusing on and what we anticipate may be coming up from a policy perspective. Our legislative session started last week. It's a 90-day session, and so we anticipate it's going to be wrapping up hopefully sometime in the May or June timeframe, if not sooner. One of the items that we do as we work through preparing for the state legislative session is we work with our policy groups and with our hospital members from across the state. And we have 123 hospitals that are members of the Hospital Association, and of which John talked earlier about critical access hospitals. We have 83 critical access hospitals in Kansas. And so we have surveyed a subset of those hospitals to really identify what are those topics that are priority issues for them. And a couple of the items that really kind of stood out for our members as we've talked with them about potential policy issues on the state level focuses on issues like telehealth, Medicaid expansion, looking at some of the COVID protections and safeguards that have been put in place over the last year, the 340B drug discount program, which I know we talked about on the federal side, but looking at whether or not there's any opportunities on the state side. Protecting healthcare workers from assault is something that I know some states have engaged in legislation in the past. That's something that we have not yet in Kansas, but it's something that we're considering and having conversations about this year, as well as looking at some anti-vaccine bills that may be coming out from a lot of the conversations that have been occurring over the last several months. Andrea, if you wouldn't mind moving it to the next slide. As we look at what our 2022 legislative platform is, it really kind of focuses on those key areas that are identified here. Looking at COVID response on regulatory flexibilities and liability protections. And quite candidly, we've seen some movement on the emergency orders that was adopted last week that are trying to be put in statute for the next several months. That was voted upon by the Kansas House earlier this week. It's going to be voted on by the Kansas Senate sometime later on today. And we're hopeful that we'll be able to get some of those provisions put in place before the emergency declaration expires at the end of the day tomorrow. In addition, CanCare expansion is something that we've been talking about for several years. We have had opportunities in some years that it has passed the legislature. Back in 2017, it passed both the Kansas House and the Kansas Senate, but it was then vetoed by Governor Brownback. Since that point in time, we haven't been able to gain as much traction in our legislature to get something to move forward. But it is something that we continue to focus on that we know is important for many of our hospitals. Telemedicine is something that we are focused on within a number of different provisions, looking at some platform protections, looking at payment parity, which is something that has been provided and afforded to many hospitals throughout the pandemic, but is not something that is will be indefinite by any means. And so some insurance companies are starting to change that philosophy as of 2022. We are looking at getting a bill introduced actually later on today, looking at putting some of the telehealth protections in place indefinitely. And so hopefully we'll be able to get some movement in our Kansas legislature focusing on that. In addition, looking at insurance related issues, whether we're talking about prior authorization, white bagging is a topic that has recently came up on the 340B program, looking at protecting the program and providing some assistance to many of our hospitals. One area that I would say is oftentimes overlooked in our legislature that is finally getting some attention is behavioral health as well as mental health. There are some opportunities to bring some additional resources and funding in that area to be able to provide the support that is necessary to take care of many of our Kansans. Those are a few of the items that we'll be focusing on during the upcoming session. I would just want to maybe highlight for a second, the governor did have her State of the State last week. As part of her State of the State, she did identify a few different healthcare topics that she wanted to focus on, and then several non-healthcare related items. And from a healthcare perspective, a couple of the items that she noted during her speech was, again, CanCare expansion and the need to do that, but also increases to mental health funding from local communities. And so we'll be watching very closely and working with our legislative leaders on those two topics to see if we can get movement on either of those topics during the 2022 session. A couple of the non-healthcare related items that the governor talked about last week in her State of the State address looked at cutting the sales tax on groceries. That's something that Kansas has, from my understanding, the highest sales tax on groceries. And so trying to eliminate that completely. In addition, she announced that she would like to distribute a one-time payment of $250 to every tax-paying Kansan. And so that's something that she's hopeful to get through the legislative process. There's been conversations about freezing college tuition rates within the state of Kansas. Investing in law enforcement was another topic that she wanted to focus on. Funding a state water plan, which is a big topic of discussion within our state, as well as improving the foster care system in Kansas, were a few of the items that rounded out her comments on the State of the State address. If you wouldn't mind, Andrea, going to the next slide. Outside of the healthcare items that I kind of articulated on the last two slides, there's a couple other things that we'll be focused on. I've already talked about the emergency management oversight and what's happening related to that. But the mandates on the vaccines will be another topic of discussion. During the special session that we had in the fall, there were some restrictions that were put in place as related to COVID vaccine requirements. However, there has been some proposals that have been made by a handful of legislators that would like to prohibit vaccine requirements for any type of vaccine. And that would even include some of the childhood immunization vaccines, which is something I believe from our perspective and a public health perspective would be quite disturbing. And so that is something that we'll be watching very closely, weighing in on, providing education to our policymakers to talk about the importance of vaccines. The one other item that has the potential to create a lot of controversy during the 2022 legislative session is redistricting, which does occur every 10 years and is one of the items where, in essence, they look at not only the districts in the Kansas House and the Kansas Senate, but also our congressional districts in Kansas, where they have to realign those based upon the shifting populations. And so there's already conversations that are ongoing in our Kansas legislature looking at the congressional maps and what changes may need to take place related to that. One that will be of high note, we'll be looking at the congressional district number 3, which involves not only Wyandotte County, but Johnson County. In the past, those two counties have been in the same congressional district. And while it's likely that large portions of both of those counties will still stay in the congressional district number 3, the population among those two counties are too large to be able to continue to keep both counties in that congressional district. And so there will need to be slivers of either Wyandotte County or Johnson County or both that will move into another congressional district. And so that will likely create a lot of conversations and discussions within our state legislature, as well as the shifting maps that we'll be looking at with the Kansas Senate districts, as well as the Kansas House districts. One other item that I'd like to note, and Andrea, if you wouldn't mind moving to the next slide, is that we do have a new KDHE secretary, and her name is Janet Stanek. Prior to serving as the acting KDHE secretary, she has been serving as the director of state employee health benefits program. Prior to that, she does have a long history in working in healthcare as well as working in hospitals. And prior to working with the State Employees Health Plan, she spent 21 years at Stormont Bell Health in Topeka, Kansas. And so someone that we have worked very closely with, that understands hospital settings, that understands healthcare. And so we look forward to working with Secretary Stanek as she continues to guide that agency and that department. She will need to get a Senate confirmation. They started having those discussions this week. And so we do anticipate that a vote will be happening at some point in time in the near future to confirm her as the permanent secretary at KDHE. So lots of activities that are going on in our state legislature. One of the items that they're dealing with, though, just like the general public, is the spread of COVID. And I know we've had a number of legislators that have been quarantined or have been infected. And so it is something that's created a little bit of chaos within our state legislature with the spread of COVID within our legislators and our elected officials. At this point in time, Andrea, I think that wraps up my slides, and I'll turn it over to John to walk through what's happening in Missouri.
And I will now quickly recap everything that's happening in Missouri. Now so next slide, please. So today is January 20th, which means yesterday, Governor Parson was able to deliver his State of the State address. And I didn't know what was going to happen for sure, so we didn't build any slides on that, but I'll give you a quick recap. Notably, that address did take place in the House chamber with a full audience this year, unlike last year when it had to be moved to the Senate chamber for a smaller audience and social distancing related to COVID. So it was good that I guess it got to come off in its normal setting, its normal manner. It is an interesting time for the state of Missouri from a sort of fiscal spend standpoint, as they're working on budget for fiscal year 2023. There's a lot of money available, and the governor, Missouri is a balanced budget state, nearly a Republican supermajority in both houses. There's actually a few open seats on the House side right now that keep it from being a supermajority. But the State of the State address yesterday was released along with some details about the governor's recommended budget. Of course, it's the legislature's responsibility to actually work through and pass budgets and then appropriate funds. But a couple of highlights here. The proposed operating budget for the state of Missouri in fiscal 23 is $46.7 billion. That is 31% greater than the fiscal year 2022 budget. So it is not thought that will be a sustainable sort of new level, but rather it contains an awful lot of proposals around one-time projects to modernize in any number of areas, largely under workforce and infrastructure. Those are two of the governor's longtime priorities here in Missouri. Why is there so much money in the budget? Well, there's a whole lot of money that has come in the form of revenue. And if you look at what makes up the 46.7 billion, the state's projected to start the year with about $3 billion in the bank and projects to spend that down to about $1.5 billion through the course of 23. General revenue, 12.1, other state funds, 11.2, and then federal funds, $23.4 billion, or almost exactly 50% of what's proposed in the governor's budget to be spent in 2023. So there are a lot of federal pandemic funds. There are additional funds that have come into the state of Missouri based on the fact that we did, by ballot initiative back in August of 2020, authorize the expansion of eligibility for Missouri Medicaid, which is projected to bring on another roughly 275,000 Medicaid beneficiaries. So that was passed in August of 20 through a ballot initiative, and then needed to be funded. I may sneeze here in just a minute. I'm fighting it off. And I am by myself in my office, so everybody's safe. But we went through the courts in the state of Missouri last year. There were some challenges to whether or not the expansion population's participation in Medicaid needed to be funded, and the courts ruled that yes, indeed, expansion beneficiaries are the same as regular beneficiaries for Missouri Medicaid, and that needs to be funded. There's an obligation there by state government. So then enrollment started in October of 2021, and people are being enrolled in Medicaid expansion. Last check, there were just shy of 60,000 of those expected 275 or so who actually have joined Missouri Medicaid as part of that expansion population. So you run through at a high level. I mean, you can go elsewhere and read the details of what was in the state of the state and what was in the budget. But the headline is that really noteworthy increase in spending, and Missouri Medicaid expansion and Medicaid caseload or utilization growth, does represent a chunk of that. Again, it's almost entirely funded by the federal government, but it runs through the state budget, and therefore it's found there. There are many other things that have been announced regarding roads and bridges and education and other things, and you can read about that elsewhere. But it is a time of unusual sort of willingness to spend in the state of Missouri. So our legislative session started about 2 weeks ago, and it runs into early May. And initial months here are hectic as well. Some of the same things that Chad discussed: congressional redistricting. We'll do federal House districts. Actually, that got voted out yesterday. And looks like it's going to be sort of status quo, not exactly, but sort of status quo, that Missouri would be likely to end up with 6 Republican and 2 Democratic House representatives after the next cycle of elections. We'll see how that goes down. ARPA is the American Rescue Plan Act. Those are federal monies. They've been sent to the state of Missouri. None of that was spent by the state government early like it was in Kansas in some areas, workforce support, things like that. Here, the governor said, we're going to put it all in the coffers and let the legislature go through normal appropriations. So there's about $2 billion that needs to be distributed, largely to schools in the state of Missouri by March 24th. So that's getting a lot of attention early in the session. And then, like I said, Medicaid expansion is another thing that's in that kind of fast track spending bill early in the session, because what was appropriated, even after the court's ruling, the court ruled after the end of the last legislative session. So there's money in the budget to fund Medicaid, although probably not enough to fund it for the full year. So there's some help that's probably coming through this fast track spending. Next slide, please. The point here is this continues to be a little bit of a political football in the state of Missouri, and will be. But as far as what's actually in the budget, it looks like there's plenty of money available to fund Medicaid as expanded. There's money that was put in as Medicaid and healthcare stabilization funds in the last budget. And then there are federal expansion incentives available to us, and they're use it or lose it. So we're hopeful that the state will move forward with that. Next slide. Just another graphic that kind of shows how we get to, essentially, there's a couple of $1 billion either already in the budget or federal money coming in, and it's more than enough to fund the expanded obligation for the state of Missouri, actually for a decade or so. Next slide, please. So I don't have as pretty a picture as Chad. I was really envious there. This is, I'm new to the job and I'm learning. a nice summary of what we're doing as an association whenever the legislature gets together. It's a mix of offense and defense, right? Pass the good stuff, kill the bad stuff. And these are a few areas where we're talking about things that we really are advocating and things that we want to pass. We've talked about a lot of them already on this call. There are a couple that I would call out. We're one big health system here. So if money is spent to improve behavioral health capacity and care in the state of Missouri, and we have crisis centers, if we have additional supply of outpatient, inpatient treatment, things like that, that's obviously very good for hospitals, even if it's non-hospital suppliers. And so we're quick to partner with others as we do our priorities. Pharmaceuticals, you can see some things there. I won't go deep on that, but there are always strategies that folks are trying to come up with. We talked about 340B. There's brown bagging, there's white bagging of how pharmacy benefit managers want to send drugs perhaps directly to recipients and then ask them to go to their doctor or their hospital to have those things administered, and just kind of ways that folks are trying to get around what would be the normal channels for distribution of pharmaceuticals in a way that is good for pharmacy companies and not so good for healthcare providers. Time critical diagnosis standards, there's a lot of attention right now, and should be, on the mechanisms of dealing with the sickest of the sick, and how we typically, how ambulance services work, how transfers work, how small and large hospitals work together, how large hospitals are organized from the ER to the floor to the operating room, diagnostics, and the rest. Time critical diagnosis standards help provide a level of quality assurance and regulation around how we collectively deal with stroke patients, cardiac patients, trauma patients, and there are always additional regulatory and legislative opportunities to improve that system. We got really close to passing some reforms to TCD structure at the end of session last year. It got defeated based on basically something that had nothing to do with time critical diagnosis. And so we're bringing that back this year as a way to continue to help our system work better in the state of Missouri for folks who need us, and have those beneficial relationships between EMS, hospitals, patients, and other stakeholders. So those are a few of our state legislative priorities in Missouri. Again, we've covered an awful lot of that, and I'd be happy to at least try to answer your questions if you want to go deeper on any particular topic. I think that may be the end of my slides. Yes, that thank you slide very clearly came from Chad because it has a picture. What more can we do?
That was awesome. Thank you so much, John and Chad. I learned a lot. I took a lot of questions down from the chat and Q&A, and then text, and I have a few myself, but we're actually going to let Molly present next. And then after her presentation, if you guys are great with answering a few questions, but I will let Molly share her slides next.
Sure. Do I need to request control here?
Yeah, you can. That'd be great.
All right. Good morning, everyone. Okay, there we go. I am Molly Hayes. I am the Director of Advocacy here at Advent Health in Kansas City. Proud member of KHA, put my little logo up there too, as I borrowed a few slides from Chad, so I want to give them some credit. Thanks to Taylor and Andrea for the invitation. They are my amazingly smart coworkers. And I'm lucky to work with KHA every day with Chad. And John, looking forward to getting to know you. So a little bit about me. I handle advocacy, or you can call it government relations or a lobbyist, for all of the Advent Health hospitals in Kansas. That is Shawnee Mission, Ottawa, and South Overland Park. And with those 3 hospitals, we have 4,000 employees. I get to handle federal, state, and local issues. All 3 of those keep me busy and on my toes. You just heard a great overview of the no shortage of healthcare issues out there. I've been proud to be here for 3 years at the hospital, and prior to that, I worked for 17 years in Congress, both in Washington, D.C. on Capitol Hill, and then locally. So that background has given me some skills on how the government works or doesn't work on the inside, and what effective advocacy is. My setup here at the hospital is I have an internal advocacy committee. Andrea Trilla is a member, thank you. This committee is made up of leaders from all over the hospital, whether it's clinical folks, human resources, finance, security, behavioral health. They're my sounding board. They're my experts within the hospital to help identify issues that come up that need to be addressed, or as issues come to me externally, I can go to this group and say, hey, how does such and such affect our hospital? And so I'm really lucky to have that sounding board of experts. Thank you for changing the slide. The next one is, what is advocacy? Here's a couple of good quotes that I stole from someone else. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And all advocacy at its core is an exercise in empathy. And I love that one, because I think what we're trying to do is just get our elected officials to listen to us, to understand our positions, and then act accordingly with that education. And the next slide, yep. If you look up advocacy in the dictionary, it's public support for or recommendation of a particular cause or policy, but I like the synonyms that they use. Really describes what we do. Supporting, arguing for something, calling for something, pushing for, pressing for, that's what we're doing. I think anecdotally, when you talk about advocacy or lobbying, folks are like, oh, it's just big money in politics and big lobby and influence, or they assume someone else will do it. So I would say that phrase that everyone uses in my space, you know, if you're not at the table, you're on the menu, is so true. Elected officials are hungry for legitimate information from their constituents. They want that, and so don't be afraid to kind of get off the sidelines and get involved. I'll say the long-lasting impacts of advocacy or outcomes can include, you know, influencing policy development and adoption, improving our government policies, increasing public awareness about an issue, changing the public's attitude and values regarding significant topics, and increasing the public involvement. Next slide. So where do we advocate? With all the issues John and Chad discussed, it's top to bottom. So U.S. Congress in Washington, D.C., we advocate with our state legislatures, like you heard, the governor's office. There's a lot of advocacy with our agencies, federal and state agencies, and then our city and county and local level. I think we've seen in the last 2 years the impact of our local jurisdictions and the interest during this crisis in local decisions, specifically with the county, public health departments, school boards, et cetera. So I think we've seen more than ever that all levels really can impact us. Next slide. What is effective advocacy? So hospitals, we're encouraged to bring our legislators, our elected officials to the hospital, bring them in, build a relationship. Building a relationship is definitely the first step before you just start asking and begging for things from our elected officials. This is a picture of our CEO prior to the pandemic. Since you see there's not masks, we do invite elected community leaders into the hospitals frequently, give an update on what's happening at our hospital, where can we work together, maybe on mental health or EMS. And you can see there's a couple state legislators, our county health department officer in there, and just ways to sit down and talk together. And so those are some ways to build relationships. Find connections when they're in session and out of session. During the legislative session, lawmakers are inundated with meetings and emails. And so I think it's just as important year-round to not only build the relationship, but find connections and common points with them year-round, where you're not just always coming with an ask during the session. Becoming their healthcare advisor, I think, is a really cool thing that I try to work on. We want to be thought of when an issue arises. Oh, I'm going to call Advent Health. They may have an expert that will know an answer on such and such policy or how they're handling something. And so kind of this education and building a relationship helps position yourself as an expert for them. Again, they're looking for resources. They don't have time to do as much resource search as you think, And so they're looking for a constituent that can come in and have stats and real world examples. Some other advocacy, and I'll talk later about outside organizations, but being involved in a PAC. The KHA has a PAC, I'm sure MHA does, and you can participate in that as a way to support our elected officials too. On the reactive side, again, I want everyone to not assume someone else will do something. There's a vocal minority that speak out on certain issues, and I hope today you're energized to speak out yourself. So on the reactive side, if you see something in the news or you're getting emails from your organizations, HIMSS, KJ, whatever, that affects your job, your business, say something. Don't be afraid to send an email or a call or text to your elected official to ask questions or weigh in on something. Again, don't assume that they already know. And when you bring them over to your hospitals, they can see things firsthand and be educated even better. I would say one of the important things as we talk with our elected officials is to thank them. Most of them are typically receiving negative emails all day, or I'm sure you've been on Twitter and that's not a positive space. So I would say, however you can thank them, either when they do vote your way or even when they just meet with your group. I don't think they get enough of that. And then it may be really obvious to say, but just be respectful. You're representing your organization, your industry. There's going to be elected officials that don't vote with you on a lot of issues, and you just need to not burn that bridge. They could be the next Speaker of the House, or they could lose their next election. So however you can be professional and respectful, that's going to be critical. And so here we talked about getting to know your elected officials. Wanted to show a couple of the leaders here, the key leaders really for each state. So on the Missouri side, the governor is Mike Parson. He's there in the center from Bolivar. The House, in Missouri House, Speaker of the House is Rob Vescovo. Hopefully I said that right, John. And on the Senate side is Senator Dave Schatz, the President Pro Tem. Leadership is so important because that's who decides what is going to be voted on. They decide the agenda, they decide what gets moved. So if you're a constituent of someone in leadership, definitely get plugged in. They will listen to you because these are the guys really deciding what goes. On the next slide, you can see on the Kansas side kind of the same lineup. Our governor in Kansas is Laura Kelly, and then the Speaker of the House, Ron Reichman from Olathe, and the Senate President is Ty Masterson from Wichita. So again, just kind of knowing the key leaders. Some folks say, I don't know who to follow on social media, or I don't know who to sign up for, email alerts. I would choose these key three leaders as they're really pushing what is moving or stopping. So next slide. And this is what I think is so important. We talked about knowing our elected officials, but effective advocacy really requires grassroots engagement. It's a team effort, and so I hope you want to join in the efforts today because it's more important than ever for civil, fact-driven education and advocacy. So you've already taken the first steps because you're a part of HIMSS and you're here, so I applaud you for that. There's a lot of organizations, there's countless groups. I just threw up some that I work with literally like this week. You may not know that your local chambers are completely plugged into policy. Some of our disease-specific groups or health groups, Heart Association, Cancer Society, are also pushing shared priorities that we have with them. And then invaluable resources to my job every day are the hospital associations. We're members of Kansas and Missouri, and of course the American Hospital Association. What is also important just for my role that might be interested in is, healthcare is so competitive, especially in Kansas City, right? Unbelievably competitive. But really when it comes to advocacy, I work extremely closely with my counterparts at St. Luke's and Children's Mercy and KU. If a policy is, improving access to healthcare, telehealth, mental health, if it's good for a hospital, it's one hospital, it's probably good for them all. So we actually work really closely with our counterparts. On the chamber side, if there's a proposal to increase workforce training and development, that's good for all employers, well, that's good for us. And so we're going to work with our chambers on that as well. Some of the issues that arise at the hospital we bring to these organizations, and then sometimes these issues, or the issues that they discussed earlier, arise externally, and then they come to us and say, "This is coming. This is a challenge that might be coming," or "This is something important. What do you all think?" So it kind of goes both ways. I would say during COVID, these organizations, partnerships were more important than ever. The Kansas Hospital Association, I'm going to keep talking about because that's where I primarily work. I mean, they've been invaluable during COVID. There's just been an unbelievable amount of information coming from the state level, coming from the federal level, and just using those channels have been more important than ever. Using every connection. Remember when ventilators and PPE was scarce early on? We used these channels and these routes to get there. There's been regulatory flexibilities and changes needed during COVID. Our federal, state, and local policies, the vaccines came from the federal level. So I would just like to point out all of these examples. I'll even give a small one early on in the pandemic in 2020. I think it was like March or April. We don't have a hospital in Missouri, but of course we're right on the state line. So our patients are in Missouri, our doctors are in Missouri, and our leaders were like in early March and April, well, what are we going to do with telehealth because of, we need these waivers. You probably heard of waivers or executive orders, emergency declarations, all those buzzwords in the news. But we actually used the Greater Kansas City Chamber and the Missouri Hospital Association, even though we're not in Missouri, but took it to the governor's office explaining how important those telehealth flexibilities were as it relates to like geographic destinations, which I know is in the weeds here, but we used these two organizations because I didn't really have a voice over there. We didn't have a hospital over there. So just an example of where you can use these critical partnerships to get something done, and it did work out, and it was handled quickly. I'm sure we weren't the only one, but really invaluable in times of crises. So I would say before the next slide, if you want to email me, I was going to have Taylor or Andrea put it in the chat, but I hope you will step up and get involved in an organization. I'm happy to connect you personally with one, welcome you in this space. So next slide. On the grassroots front, there are tools at your disposal that are super simple. When I started on Capitol Hill in 2001, I literally sorted faxes that came in and blast faxed press releases. We had to sort like hard copy mail. It is so much easier now to not only communicate with your elected officials, but for them to actually have it sorted and easier for them to read too. So you can go to the AHA website I listed here. It tells you, what are the priorities we want to push for at the hospital level. It'll include fact sheets, stats, sample messages. I mean, it's so easy to contact your elected officials. And same with KHA, you can go to their grassroots website here. And Missouri, I'm sure you have one too. But you can just click in your address, your name, an email can go directly to your state legislator. So there's no excuse. It's easier than ever to reach out to folks. And I did see that the HIMSS website has an action center on your policy center too that has that. So it's very easy. We're all busy, but I hope folks will take time to do that. On the next slide, you can see even as a Joe citizen, how do I find my legislator? You probably don't know your state rep or your state senator. If you do, kudos to you. It's easy to go to find your legislator, type in your home address, and it literally brings up your elected officials. Let's see, if you go to the next page, I typed in the address here where our hospital is in Shawnee Mission, so State Rep Jared Osley came right up. The page, this is the Kansas site, will show you their district map, their voting record, the committees they're on, what legislation they sponsor, and then most importantly, their contact information. So you should be able to easily get that on the internet these days. You can blast email all our legislators. I really just recommend communicating with yours, or maybe the ones just on a committee that will listen to you. They want to listen to their constituents who vote for them. On the next slide, This is the Missouri General Assembly site. Same thing, super easy, like right in the middle. Find your legislator, enter your address, and if you go to the next slide, comes right up. I live on the Missouri side. Put my home address in. Patty Lewis came right up. She's my state rep. What I want to show out on the Missouri side slide, though, which is so cool, is Capitol Report sign up right there in the middle by the arrow. You can just sign up for your state legislators' email newsletter. And those usually just include a few highlights of what's gone on that week or for the session, because I know everyone's busy and doesn't have time to watch every little thing. So recommend signing up for your elected officials' communications. Or like Jared Ousley on the Kansas side, they don't have it on the Kansas side, but I just Googled him and his campaign website came right up and you can sign up. Your federal officials all have newsletters you can just sign up for. Same with the county and the city of Overland Park, or city that you reside in. Next slide. There we go. Scary, I know, but social media is a huge piece of advocacy. If you're interested, follow your city council member, your mayor. You can find out about a town hall meeting. You could find out what issues they're pushing for or against. If you want to be a positive advocate in social media, like, comment, share things, share the Missouri Hospital Association post, share the American Cancer Society post. Elected officials absolutely pay attention to social media. So I think I recommend you become a positive voice in that space. Everyone can be an advocate. You don't have to be me or Chad or a lobbyist or whoever. Anyone can be an advocate, your neighbor, your husband, whatever. Advocacy is, never finished. It's ongoing. And so that's kind of what I want to leave you with. It's something that's constantly, you need to educate. There's constantly new elected officials losing election, winning election. So it's ongoing, and hopefully job security for me. That was kind of the overview of how advocacy works. I am happy to answer questions. John and Chad know a lot more than me. So thank you.
Excellent job, Molly. I appreciated that very much. I wrote down my quote of the day is, if you're not at the table, you're on the menu. I'm using that one, so I appreciate that. I wanted to start with a question from Dr. Denton Shakes, who's a physician at KU. It says, please comment on interstate or national medical licensure for telehealth and virtual care. How do doctors care for their patients that are truck drivers, college students, travel for work, live on the border, or go on family vacations and need continuity of their primary and specialty care? So that kind of goes along with some of the telehealth things you were discussing. So I don't know who wants to take that one.
I'll start. So medical licensure is not nearly as far along in regard to reciprocity and compacts and things across states as perhaps nursing or some others. And you have individual, in Missouri, you've got the Board of Healing Arts, you have individual organizations that have some governance and standards in that regard. It's an area that we all see as being ripe for modernization, I guess. But whenever we're making that case, which we do to the best of our ability, there's always a stakeholder that it represents current state. And so, we had waivers in place in Missouri related to the ability for providers to practice across state lines or without a Missouri license, and telehealth and some things. And those expired for us at the end of 2021 when the public health emergency went away. And so now we as an association are working with Board of Healing Arts to figure out how we can, at the very least, expedite requests that are coming in for credentialing and authorization to work in Missouri. Broader trend, which is what I think you're asking in regard to telehealth and eventually, new models of care where I'm interacting with my care team and my doc through this thing, no matter where I am. And hopefully at some point I've got my record accessible and ready to be used. I think, one of the things that often limits innovation are these sorts of barriers and things that are built in place in the current regulatory framework. And that's the kind of work we do, is to make sure that we revisit. There usually was a reason that things were done a certain way. Sometimes it's not the best way anymore, and you have to work hard to make that case. But yeah, you're always messing with somebody else when it comes to control and authority. Oftentimes you're dealing with folks who have really good intentions, right? It's not a pure control thing. It is, they want to make sure that the quality of care, the accountability, all those other things are what they should be, and that existing mechanisms can remain in place to ensure quality of care and what's best for patients. So I'm not trying to paint this as a good guy, bad guy thing, but I do think particularly you ask a great question about the future of interstate reciprocity, licensure, nursing compacts, things like that that are in place. And I think we all believe that those are going to be central to the health system of the future. I also want to say, Molly, really good job. That was a great presentation. Thank you.
Yeah, she did a really nice job. And just maybe one other comment from a Kansas perspective. I think John covered that. There's kind of a short-term, long-term strategy as it relates to that. And I know some states, and we were able to get it passed in Kansas on the Interstate Medical Licensure Compact for Kansas. And we have a couple of the surrounding states, I believe Nebraska and Colorado, have joined that compact. And I know Oklahoma and Missouri has looked into it in the past as well. But through this COVID pandemic, there are opportunities, and we've had some opportunities to be able to waive some of the ability of these licensure restrictions that are out there. And that's one of the items that I know our governor issued as part of her executive orders last week that we're trying to put in place, at least through the latest surge that we've been going through that could last these provisions through May, possibly through the end of the year, just to be able to provide some flexibilities. But it is something I think, as we're talking about telehealth and we're having discussions in our state legislature on telehealth policies and provisions, that those are items that, we're trying to bring to the forefront and educate our policymakers on. I don't know, Molly, you kind of referenced telehealth as well. Any comments from your perspective?
I think you got it, other than I'm just trying to educate people that it was expanded during the pandemic with these flexibilities, and it's not here to stay if we don't make some changes. So feel free to let your lawmakers know that.
Okay, excellent. There is another chat that I will kind of elaborate on a little bit. It says, would you be able to give us an insight on the challenges healthcare stakeholders are facing handling data integrations and interface engines? And I'll elaborate on that a little bit. I know that some of the 340B drug companies are requesting data interfaces. Some of the payers are for reimbursement bonuses and things. And it puts a lot of the burden on the hospitals to make sure that they're sending what's requested to all of these third parties. And so I just wondered if there was any conversation about standardizing data send or having those third parties be able to access the data on their own. I just think it's going to be harder for healthcare organizations to maintain multiple interfaces with these outside organizations.
A quick comment. So Missouri Hospital Association has one of its companies is the Health Industry Data Institute. It's called HIDE. And we actually were a contractor last year to help connect hospitals around the state using ADT feeds into something that could be used for care coordination. That meant we were working with health information exchanges that are doing business in the state of Missouri. So hospitals could either connect directly with us, or we could get that through their HIEs, Lacey, Tiger Institute, Missouri Health Connection. The problem of interoperability. I told you I was at Cerner for 11 years, and actually I looked at the participant list. I want to wave at like 5 of you. I think I know some of the crew here, even though I can't see all the faces, but continues to be a real challenge. It is something that does get a lot of our attention, and the work that we did with Heidi last year in the state of Missouri was funded through a 90-10 federal match opportunity for the state of Missouri. And so as a result of some good advocacy to invest in interoperability, funds were made available to help improve that space and make some of these things a little easier on a go forward basis. And so then we turned around and we gave money to each hospital that connected to offset their cost and trouble. And then we also, like I said, were able to go to HIEs that maybe were already getting that data.
Great. Yeah, that's going to be an ongoing challenge over these next few years for sure. Molly, I'm going to put you on the spot. I know that you sent out some information this week on the Violence Against Healthcare Workers Act. I just wondered if you could elaborate on that a little bit. I know that there's a lot of hospital-based people on here, and that's a great issue to lobby around in Kansas. It's definitely a hot topic.
Sure. And Chad and John, jump in too, because you have more experience on this like exact issue. It's a national problem, but you know, here at Shawnee Mission, like you know, Andrea, this was a huge problem before COVID. I think with the focus on the workforce crisis, lawmakers are wanting to do something for workforce. So I think as far as a legislative strategy, we're kind of thinking, well, maybe we can strike while the iron's hot on this topic and really get something meaningful through. So we're still in discussions with different groups on what that looks like. Some states like Tennessee last year raised the penalty to a felony for assault on a healthcare worker. We're looking at some different avenues, maybe interference statute like we have with EMS, and maybe just increasing the penalties. We had a meeting with the Johnson County DA that was really productive on how we can get more of these crimes prosecuted. But yeah, I think it's a great topic that's very bipartisan. There's bipartisan interest, which is really fun. Chad, what am I missing?
No, I think you covered it. And obviously this has been an issue even before COVID, but now in today's environment, I know I hear from hospitals from across the state that if you have screeners that are screening for COVID, that you have family members, you have visitors that are a little bit more abrupt in terms of some of their interactions with our hospital staff members. And so really just providing protection to our healthcare employees as we're trying to serve and treat our community members. I know it's a very complicated issues in some respects. There's been conversations I know in the past as to are there exemptions, exceptions for folks that have mental health diseases or challenges, and obviously, you know, what we're wanting to do is to minimize these types of interactions, not only with our patients but also with our visitors that are coming in, family members. It's already a high stress environment. We don't need to have these types of situations occurring when we're trying to really do the best that we can in addressing the care needs of our community members.
You know, you go work in a hospital or hang out in a hospital for a little while, you see the amazing things that nurses and other frontline folks deal with, and the way they handle conflict, the way they redirect, the way some of them are really mistreated by patients and others. That should not be, right? And there is a tension in some cases between regulatory agencies, right? You've got CMS that wants to make sure that we all are doing a good job of respecting patients, providing good care, and keeping patients safe. Then you've got OSHA on the other end saying you got the occupational safety folks saying you got to keep your workers safe. And sometimes there are conflicts between workers and patients, and depending on which agency is looking at it, you know, everybody's wrong. And these are difficult circumstances. We do work through them. We try our best to hear from members when there are problems, when there are citations from a CMS standpoint, and make sure that expectations are very realistic about how healthcare workers are able to protect themselves and others in these tough circumstances. Because there are times that folks are blamed for what we think is a sort of normal human self-defense kind of reaction. And so I'm not trying to paint one side or the other as always the bad guy. We all know that's not the case, right? There's always two sides of the story and gray area, and there are bad actors of all shapes and sizes. But this is a tough issue, and one that I agree it's bipartisan in support of protecting and respecting healthcare workers, and we continue to advocate for that.
Great. There was a question that came in around supply chain issues nationally. Drug shortages have been a hot topic. I sat in a meeting this week about saline flush shortages. I mean, really kind of odd things and what's coming in and what's not. Is that part of the Build Back Better to add more resources to some of those drug companies and things to increase production? I know that we're going through a lot of medications with the amount of beds in use. PPE, other supplies, is that part of a national strategy? Is that more local?
Well, there has been conversations, obviously, on the federal level as to how do we address some of these challenges and ensuring that we're able to get our supply chain back at a manageable level. I know that's been a challenge that we've had not only here recently, but over the last, 2 years through this pandemic of getting access to some of the supplies that are needed out there. I know John and myself work with a variety of different organizations to really work with them in our hospitals to be able to ensure that what is needed is being available. But there continues to be challenges I know that we hear sporadically throughout our state. I don't know, John, any comments from your perspective, or Molly?
You nailed it. It's not just a national, but rather a global issue. So much of what we use is manufactured around the world, and we all know of all the barriers that have been placed, and we see folks being creative about making things work. We've tried, of course, to advocate for building a bit more capacity, right, in some areas. I talked about this earlier. If you belong to the cult of efficiency and real-time sourcing for everything, boy, you don't have much resiliency built into your system. And so I think we will continue to advocate for some level of emergency preparedness, disaster preparedness, and resiliency, and that having some inventory on hand isn't a failure.
Wonderful. Well, that is actually all the questions that I had come in for now. So I will let each of you, if you have anything else to add at the end, what you'd like to see from this group or people listening today. I know Molly provided some great resources, and we can share those slides about ways to get involved locally and kind of being aware of what's happening in your region. Any other thoughts?
I would just mention thanks again for the opportunity to provide some comments today. Your involvement, the work that you're doing in your local organizations is much appreciative. I know it's been a challenging 2 years for many of our colleagues in the healthcare industry, but really appreciate everything that all of you are doing and the opportunity to kind of highlight some of those discussions that are happening within our 2 states. At the same point in time, if there's anything that we can do from a hospital association perspective, please don't hesitate to reach out to us.
Wonderful. Well, thank you all. Those were excellent presentations. John, were you going to say something? I may have just cut you off. I apologize.
I really don't need to. It's been well said. Available at any time. Our organization exists to advance health across the state. We do that through our members. If we can be useful, we want to.
Excellent. Well, I appreciate your partnership and all of your time today. I know you guys are very busy right now, so grateful for this event and excellent information. I'll give everybody back a few minutes and enjoy the rest of your day.
Take care.